Sorry, there's lots of people jumping in. My screen. Okay, thank you everyone for coming along. Welcome to today's lunch and learn session, which is around navigating complex conversations. If this is your first session with us, welcome. My name's Kathy Kirby and I am a registered nurse and one of the directors at Thrive Aged Care Consultants. With me today, I have Kate Lamont, who is busily letting everybody in and we'll be monitoring the chat today. Kate is co-director and is an occupational therapist at Thrive, and together we love doing sessions like this. Our mission at Thrive is to support you guys who support older people, no matter where that may be, and we do that through doing things like today, through education, training and mentorship, as well as some organisational support. So if you like the training today and you're interested in having some more, talk some more about training for your organisation specifically, let us know. You'll get our details at the end. A bit of housekeeping. As you can see, lots of people jumping in. We're expecting a lot, so we appreciate you being on mute and for entering on mute. It makes our lives a lot easier. We will have time for questions at the end of the webinar today, and we will stop recording so that you can ask questions freely. This session is recorded and it will be uploaded onto YouTube, so sharing is caring. Use this training for your team members and send the link along. And please do use the chat box to ask questions or make comments and communicate that way until the end, just to ensure that we run on time. And as I was saying, we are recording already, so thank you for that. So today's session, we are talking about complex conversations, and this is a topic that has been requested over the last year a few times now, and particularly after last month's session, which was all around dignity of risk. So if you haven't seen that webinar, you can find that on our YouTube channel as well, if that's a topic that is of interest to you. But today we're going to be talking about why complex conversations can feel so challenging. And we're going to talk about how we can better prepare for having these conversations and discussions, whether it's with the people who we're providing care for, their supporters, or potentially even staff members who are a part of our team who we need to have a conversation with. And we're also going to give you some practical strategies, as always, for clear and effective documentation for these conversations that we're having. So to start off with, I want you to have a think about a time when you were leading, or perhaps you were a part of a complex conversation. And it could be on any topic, because we know anything can be complex depending on lots of factors. So what were two things that made it complex or challenging for you in that conversation? And just have a think about it and pop it in the chat. What were two things that made that conversation feel complex or felt like it was a real challenge for you to participate in? And I'm just going to wait for a minute because I know that chat was lagging last month. One thing that can be complex is expectations of the person or the family members. Yeah, unpleasant topic, fear of being punished for raising an issue. Absolutely. Not having confidence. Person's willingness or readiness to engage, time constraints, unpleasant topic, emotions, person getting defensive or distressed and not sure how they will take the conversation. Yep. No good outcome. Talking with someone who doesn't have insight or lacks insight and ability, balancing rights, information that people don't want to hear. Absolutely. Nothing is a surprise there to me, and I'm sure that none of these will be a surprise to any of you guys either, because you're all very consistent in what you're saying makes things complex or challenging. Different expectations from different people in the room. Absolutely. So lack of confidence, having conversations with people and leading complex conversations is a skill. And it's not necessarily a skill that we teach. And, there's lots of factors involved, which we're going to be talking about in a minute. But I think you raised some really valid points there around it can be related to the topic that we're talking about. It can be related to the confidence in our own skills, being able to lead that conversation, as well as, that fear factor of having the conversation in the first place, but potentially who we're having that conversation with and that different personality type or emotions that may be involved in that as well. So why are conversations complex? And I sort of touched on that already, but we are humans dealing with humans. And sometimes I think we forget that in our roles because we forget that we are not robots. We have emotions ourselves, and the people who we're dealing with are also going to have emotions. So even simple conversations that we have can sometimes feel a lot more complex than what we thought it would be. And that can be because there are many different layers involved in these conversations. We have emotions. So we have emotions on behalf for ourselves. So we don't live in a bubble. We might be having a stressful morning. We might have stresses at home. We might, the person who we're having the conversation with may have stresses, again, that we aren't aware of. They may be experiencing fear or guilt or a feeling of discomfort as well about the topic that we're discussing, or depending on who we're talking with, if it's a family member, they might be feeling emotions such as guilt or fear around the conversation that we're having and the decision that might be having to be made. There are complexities as well. So again, ourselves, we're human. We're not robots. We have our own feelings. We have our own ethics. So potentially when we're having a complex conversation, it might not sit comfortably with us because it's a topic that we don't necessarily agree with or we don't feel comfortable with. We have, regulatory requirements. So as an example, again, last month we spoke about dignity of risk, and potentially we might have a level of discomfort having a conversation with somebody who wants to do something that is risky that we feel uncomfortable with, but having to lead that conversation and come up with solutions to minimize that risk may lead to us having concerns for ourselves around our own requirements as well. We have family dynamics. And I'm sure that even though your cameras are off, we're all nodding that we often manage and work with people where there are family dynamics involved. And that might be between the person who we're caring for and a child or a sibling, or it might be between the siblings themselves who have the parent who is receiving your care. So there's always complex family dynamics that add that extra layer to a conversation and challenge as well. And there are also cultural differences as well. So we have different values and beliefs, which is fine because so do the people that we provide care for. But sometimes that can add a layer of complexity, again, if we're having a conversation that we are not necessarily comfortable with because of our cultural background. We also work with people who may have some challenges with communication or changes to their communication skills. So, for example, having conversations with somebody who is living with dementia or living with another cognitive impairment or disability, and having to lead a conversation which may be more challenging because there are some impairments, and we're having to think about how we can explain things and have a conversation in a different way to make sure that that communication is really clear. There's that level of uncertainty as well, particularly now when we have the new focus on supported decision making and really ensuring that we are speaking with the older person themselves rather than bypassing them and going to their family member. So who is it that I should be talking to now? And, how do I document this conversation and who do I share that information with? These are thoughts that can be going through our head when we're having the conversation. And a fear of reprisal as well. So I think somebody put that in the chat, fear of, what goes wrong? What if I don't do the right thing? What if the person isn't happy with this conversation and they make a complaint? If they make a complaint to the commission and then we have regulatory action happen, or what if something bad happens after I've had this conversation with Barry about the risk activity he wants to undertake and, something happens? All of these things are added layers of complexity to what could be often what might look on paper like a very simple conversation. So we can see from here that facilitating conversations is a skill. Lots of different factors involved, and we need to be aware of that to start with before we move any further, because once we have that awareness and are okay with the fact that it is complex, then we can look at how we can minimize the stress and the other factors associated with having these conversations. So I'm going to talk about a scenario now, and this is a true scenario again, and this is about Margaret. So Margaret is a 96-year-old and she lives in residential aged care and she has very advanced dementia. She completed her advanced care plan years earlier when she had very early onset dementia, and it was very clear, written actually very well for an advanced care plan. And that was, she did not want to go to hospital. She didn't want to be resuscitated. What she wanted was to be treated conservatively in her own home, which was a residential facility, to have antibiotics, give it a go, and if it doesn't work, to be kept comfortable. Now, Margaret got a chest infection when she was in her residential aged care home, and she was seen by the doctor and they felt that she needed a trial of IV antibiotics. Now, Margaret's daughter, Jenny, requested that she be sent to hospital to have this treatment done, and she is. So why do you think this happened? So Margaret had a very clearly documented advanced care plan, completed in a lot of detail. Her wishes were very clear, but Jenny, Margaret's daughter, wanted her to go to hospital. So why do we think that the transfer happened? Pop it in the chat. Any thoughts? Yep, possibly daughter applied pressure, insisting on the transfer. Yep. Any other thoughts? Decision not to transfer felt uncomfortable. Yeah. Daughter and staff perhaps thought it was an easy fix. Lack of capacity to make decisions, and daughter is a power of attorney. Perhaps they didn't check the care plan. Yeah. Daughter changed her mind, may have come from the GP. Daughter not wanting to let her mum deteriorate, denial of the stage, duty of care. Yeah. Wow, amazing answers. And all very true. And again, I think we can all agree, probably a lot of these factors were involved, because when we think about this scenario, this wasn't an acute injury. Okay, this wasn't Margaret having a fall and having a hip fracture and being, in acute pain where maybe she might have needed some additional emergency medical assistance. This was a chest infection. Okay, so let's have a look at what actually happened in this scenario. And you guys were right on the mark. Margaret's daughter was really upset. She was visibly upset, and she wanted her mum to have the best care possible. Okay, that's the words that her daughter used. The nurse that was on duty, who was facilitating this conversation, was inexperienced. So she actually did refer to Margaret's advanced care plan with her daughter, but she was also fearful that she was going to get in trouble for not following the daughter's wishes, because her daughter had, as you said, made complaints before. So she was worried about getting into trouble herself. The nurse wasn't confident in how to lead the conversation about Margaret's wishes, and therefore she decided to do what was best for her daughter. Okay. Now, is this the outcome that anyone really wanted? I would say no, because Margaret has advanced dementia, and I think that we all know in the room that going to hospital and sitting on a trolley and in a crowded, noisy environment while you're unwell is not the best environment for Margaret to be in. It wasn't her wishes. And ultimately, the question here I think that we need to know is, what was it that Margaret's daughter, she wanted her mum to have the best care, but did she understand where that best care would be provided? Okay, and I think that comes back to being able to have the skill to facilitate these kind of conversations with the people who we're talking with. So where are the gaps in here? And where are the gaps with, having these complex conversations? Because we do learn communication in uni. I mean, I went to uni a long time ago, but I do remember specifically having communication as a topic. But do we cover these kind of skills? I don't think we do, and I'm happy to be corrected if there's any younger people here who've done the training recently. But I think we have a really good skill generally to be able to problem solve, and we can sort of look at a situation and say, I don't actually think it's in Margaret's best interest to go to hospital, but our skills, our problem solving skills, sort of stop there because we don't have the skills to be able to navigate the other person's emotions and stress. So Jenny was obviously distressed that her mum was unwell and could possibly die. To have emotional awareness about our own feelings. So, you know, how is our decision making impacted by our own beliefs or values, or where are we triggered when we're having a conversation by something that might have happened in our own lives? So being able to be aware of that and knowing that how that might be impacting on that conversation. We do not teach people the skills of actually having the topic itself. Okay, so we cannot expect people to have proactive conversations about advanced care planning if we don't talk to people and teach people how to actually do an advanced care plan. And please let me know in the chat if you actually receive training on how to do this, because advanced care plans, I can tell you, we go out a lot and I can pick up 10 different advanced care plans and most of them will not be filled in good detail. And that's because we don't have the skill to understand what an advanced care plan should look like. So the skill to actually have about what the conversation is about, okay? And then the skill of how to actually have that conversation on what can be a difficult conversation. You know, what would you like to do if you become unwell and you could potentially die? That's not a simple conversation to have. Okay, so if we don't teach both of these skills together, then we are going to always be reactive rather than proactive. Okay, the other thing that we don't teach is mediation skills. We deal with family conflict. You know, for example, in this scenario, it's not really family conflict, but you know, how do we have these mediation skills to facilitate the conversation and get to the root cause of what the feelings are for that other person? So in this case, the advanced care plan is developed. It's really clear, but Margaret's daughter doesn't actually want to follow it because we haven't been able to get to the bottom of why it is that Jenny wants Margaret to go off to hospital. Okay. So these are all skills that we need to work out how we can teach ourselves and our teams. And I can see a few people talking about some training, and I'll refer back later. And yes, I did do the Austin training many, many years ago. But again, that was when I was in acute health. Okay. So how can we do things better? How can we prepare ourselves and our teams better for having these complex conversations? The first thing that we need to do is to normalize complexity. Okay. We need to acknowledge that even a simple topic may be complex and challenging for different reasons. And we spoke about these earlier. Feeling discomfort and feeling when having these conversations or not feeling comfortable with certain topics is not a failure. We need to assure ourselves and assure our team members that we are human and there are some things that we may not feel comfortable discussing because of cultural reasons or our values or beliefs, but that is not a failure. Okay, so it is important that we understand and we normalize the fact that having a day-to-day conversation every day with lots of different people and feeling that complexity is completely normal. Now, I've got in red here, using a framework. I'm going to give you an example in a minute, but frameworks will reduce anxiety and improve consistency. I cannot tell you how many times I have gone into a meeting with a staff member and I have pre-prepared points that I want to discuss because I know that the person I'm having the conversation with is going to have different views to myself, and I feel a little bit anxious before I've even had that conversation. And when I put it down in writing, it helps to keep myself on track to have that discussion and make sure you're covering off all of the points that you want to cover. So using a simple framework such as ISPA, which is what I'm going to talk about later, can really help to guide that conversation, and it helps us to make sure that we're documenting clearly as well. Don't go pick another random framework. Use something that's already being used, okay? We also need to strengthen knowledge in complex areas. So we need to give people the skills to be able to have and facilitate these conversations and to how to document them. But we need to teach them the actual topic itself. So in this example, what is an advanced care plan? What do the different options in the advanced care plan mean? And, how do you document that? How do you fill it in? How do you, what does it all mean? If you don't teach a brand new nurse all of those things, then they're not going to have that conversation. You won't even get to step 2. Okay, so we need to make sure we have both skills in having the conversation and in the actual topic itself that we're discussing. Practice real scenarios, and your cameras are off, but don't eye roll me. I'm not necessarily saying role play, okay, because nurses generally eye roll when you say that. However, I'm talking about using case studies. So yes, you might use role play, but you don't have to. Use a case study. Use Margaret's case study. Hey, this is what happened in this scenario. What do we think happened there? What went wrong? How can we do things differently? What kind of ways could we have that conversation? Okay, so practicing and discussing, because that will tell you where you need to focus some attention as well. And create debrief opportunities as well. We know that we have a requirement to have psychosocially safe workplace. Okay, so don't be reactive. Don't wait until it all hits the fan. Okay, have things set up in place so that you have opportunities to talk about, I think this is escalating or this has happened, and have those opportunities for debriefing as well. So documentation, let's talk about that. If it isn't documented, it didn't happen. And I can tell you, we have an issue with documentation here. And I know it is ridiculous, the amount of paperwork that we need to complete. That's a whole topic on itself, but we do need to document, and we need to document clearly when we're having these complex conversations. And again, having a framework to be able to guide that conversation initially and to prepare and plan and feel more confident is also a way that we can help our teams to be able to document more effectively. So when we use something like ISPA, we can formulate the points that we want to cover. So we can refer to it and make sure that we keep on track and make sure that we are covering everything that we need to in this complex conversation. And again, it does help you. I've used it myself to feel more confident for the person who is leading that conversation, because it gives you more structure to follow. Now, I'm going to give you an example of how we could use ISPA in the scenario that we had with Margaret earlier. And if you haven't seen ISPA before, this is an example of the form on the right-hand side. So it's ISBAR. I is introduce. So, hi, Jenny. I'm Mary, the nurse in charge, and I'm looking after Margaret today. So already we think that we introduce ourselves really well, but sometimes we don't. S is for situation. So at the moment, we know that mum has a chest infection, and we also know that she needs some antibiotics, and we're able to give her those antibiotics here in her own home. Okay, so we're explaining what's actually happening currently. B is for background. Now, we know mum has previously completed an advanced care plan, and it says that she doesn't want to go to hospital. She's also got advanced dementia, so going to hospital is not the best option for mum's well-being. Moving somebody, but like your mum, when they have advanced dementia and they're already really sick, can actually make things worse. And what the hospital is going to offer as treatment is what we would already be doing if mum stayed in the home. We can offer that here. So you're explaining in more detail here about why it isn't in Margaret's best interest to go to hospital. And it's also reassuring her daughter that she's still getting the same treatment, because she wants the best care for her mum. Okay, so it's offering that reassurance and that explanation that she will be getting that in her own home, because going to hospital is not going to make things, it's not going to be anything different. If anything, it's going to be worse. A is for the assessment. So what's going on now? At the moment, mum's got a temperature and she's quite unwell. Her wishes are to be treated with antibiotics in her own home, which is what we're going to arrange. And then we're going to keep checking her observations, and the doctor will keep checking in and reviewing her every day. I can see how distressing it is for you, but rest assured that you're doing what your mum wants, and we will make sure she's well cared for in the environment that she's comfortable in, by the team that she knows. And then finally, the R is request. So opening it up to Jenny. What would you like to discuss anything with me? Are there any concerns or questions? Does that make sense to you? Okay, so you see how this is a much more guided conversation than going in unprepared as an inexperienced nurse with Jenny, who's made complaints before, and saying, "Oh, mum needs some antibiotics, and we're going to do that here." And then Jenny says, "I want mum to go to hospital," and we not have that background and that information to be able to share with her. So it puts us on the front foot. Is one way of saying it, to say, this is all the information you need to be aware of. You are going to be making the best decision for Margaret, and also following Margaret's best wishes, and also assuring her that she's getting the same care that she would in hospital. Okay, so it's really opening up that communication, and you can see here that it's documenting that conversation really well as well. So when we don't teach the skills, and when we don't use a framework, and we don't follow through with all of these steps, what we can see, I'm going to give you an example of some of the documentation that we see around. So having the conversation is one thing, having the skills around the topic, having the skill around communicating itself is one thing, but we also need to teach people how to document. And yes, we should learn this in uni, we should be able to document, but when people don't have the skills, we start to see things like this. And put in the chat whether these seem familiar to you. We've got example A of Joan's progress notes, a different resident. And I'll just summarise it. Attempted to discuss Joan's advanced care plan with her today in a private setting during a period where she appeared settled and alert. The purpose of this discussion was explained, including the opportunity to document her preferences regarding future healthcare and decision-making. Joan stated she did not wish to engage in the conversation at this time and declined further discussion. She did not experience distress, but was clear in her preference to defer. Joan's decision to decline was respected. No concerns regarding acute capacity to decline the conversation were identified during the interaction. Blah, 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 blah. All option B, Joan's progress notes. Attempted to discuss Joan's advanced care plan with her. She declined to have the conversation. Advanced care plan remains incomplete. Revisit and attempt again next resident of the day. Any thoughts around these two options? Do they seem familiar to you? Are they something that you have seen? Because these are two examples that we see quite often. Example B is well, I tried, very minimal. I tried, but I actually didn't have the skill or the confidence to lead that conversation. So I tried, I'm going to document I tried, and then my work here is done. And example A is saying the same thing, but it's a lot wordier. And it's a lot wordier because somebody has used ChatGPT. Because people are not confident to be able to document what the conversation was or wasn't as it happens. So we're now relying heavily on AI to write this documentation for us, which is another area that we could do a whole lot of training on. But it is highlighting, again, same skill gaps, because the conversation at the end of the day didn't happen with Joan. And it didn't happen with Joan probably because the staff member wasn't confident, wasn't skilled in understanding an advanced care plan, and wasn't confident and skilled in actually sitting and having that conversation with Joan. So the outcome is the same. Okay, so it's really important. That's what we need to focus on, is upskilling those skills, upskilling our staff with those skills in all those different areas. And again, using something like ISPA can help the person feel more confident because they can pre-fill in a lot of that information as well. So in summary, health and aged care is very complex. Conversations happen every day, and they're not necessarily, it might seem like a simple topic, but it can be complex depending on lots of different variables, such as emotions, etc., that we spoke about earlier. Facilitating complex conversations require those skills that we must teach. So in the topic itself, such as an advanced care plan, and then how to have that conversation, and then how to document that conversation so that it truly reflects what occurred. Using a framework such as ISPA can help with confidence to not only facilitate that conversation, but also to help with that documentation. If it's not documented, it didn't happen. And practice is really important. So setting up that environment for safe discussion and learning, discussing scenarios rather than role playing can help assist the team to build their skills and confidence as well. But again, it's a really interesting topic and something that has been raised multiple times. And I hope that a couple of these tips and tricks are helpful for you. We will open up for questions and thoughts in a minute, but just to let you know as well, having conversations, you need leadership as well. So having conversations, communication, all these kind of topics are the skills that you need to learn. In terms of training, we have a couple of different training programs coming up. We've just released our leaders program on our open learning platform, which covers communication is one of the topics. And we are also releasing an understanding capacity course later this month as well. And we'll send you some information after today's session with all of your links to the recording. Before we jump off, I will stop recording. Thank you for coming along today. We will take questions, but if you could take 1 minute to give us some feedback, we do appreciate this for our own continuous improvement, and let us know what topics you would like to discuss in future Lunch and Learns. But I will stop recording now, and if anyone has a question, you can raise your hand or pop it in the chat.